Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for very high impact pharmacotherapy services. So I humbly urge you all to sit back and spare me part of your very precious time to share with you some very precious tips which may prove very handy in your line of duty. So I welcome you all to part 128 of our Pharmacotherapy MCQ series, Majoring in Infectious Diseases. Welcome. And the first question reads, Mrs. KJM, a 57-year-old female patient, presents to your accident and emergency department complaining of a sudden onset cough, fevers, chills, fatigue, and a shortness of breath lasting 4 days. Some of her pertinent vitals include a respiratory rate of 32 breaths per minute, a blood pressure of 125 systolic, 72 diastolic, a heart rate of 98 beats per minute, and her oxygen sats are 93 on room air. She has a WBC of 19 times 10 power 3 cells per microliter, and her body temperature is 38.9 degrees centigrade. She has a BUN of 18 milligrams per deciliter. She is alert and oriented, and that is established on 3 occasions. A chest X-ray is done, and it shows left lower lobe consolidation, and a diagnosis of community-acquired pneumonia, CAP, is made. And my question 2 is, kindly compute Mrs. KJM's CAB 65 score. Is it 4, or is it 3, or is it 2, or is it 1? I'll give you 10 seconds to compute the correct value. So this lady has a CAB 65 score of 1. The only thing that is off the mark is the breathing. She is gasping for air, and her respiratory rate is 32, which exceeds the 30 mark. So she scores a point for that, and she does not meet any other CAB 65 criteria. She's not confused. The BUN is 18, so she does not have uremia, and even the pressures do not earn her any point, and she is less than the age of 65. So I would score her 1. Let's move to the next question, please. And it reads, Miss LMW, a 4-year-old girl, is rushed to your pediatric accident and emergency department complaining of cough, malaise, sudden onset fever, which has lasted 2 days. She has no known past medical history, and she hasn't been exposed to any antibiotics. She is up to date with regard to vaccination schedule, including H influenza type B and even the pneumococcal conjugate vaccine. On physical examination, fever is established. Her body temperature is 38.9 degrees centigrade, but there are normal breath sounds, and physiologic parameters. She's otherwise normal. A diagnosis of suspected community-acquired pneumonia is made. So my question to you is, which of the pathogens listed below is most likely the cause of this community-acquired pneumonia in Miss LMW's case? Is it the respiratory syncytial virus RSV? Is it Mycoplasma pneumonia? Is it Staphylococcus aureus? Or is it Streptococcus pneumoniae? I'll give you 10 seconds to choose the correct answer. So respiratory syncytial virus RSV is the pathogen, the most likely pathogen here. Now data demonstrates that viral pathogens are the most common cause of community-acquired pneumonia among preschool-aged children. Among the viral pathogens, respiratory syncytial virus predominates. Now Miss LMW is also vaccinated against the most common typical bacteria causes of CAP, which are strep pneumo and Haemophilus influenza, and that makes these pathogens less likely to be the causes of her community-acquired pneumonia. Now, based on the sudden onset, the clinical cause does not fit with a typical pneumonia, such as Mycoplasma pneumonia, and that makes answer B incorrect in my opinion. Let's move to the next question, please. And it reads, Mr. MSR, a 47-year-old male patient, presents to your accident and emergency department with a past medical history of hypertension. And today his chief complaint is an unproductive cough, malaise, headache, body aches, and subacute fevers. Reverse transcription polymerase chain reaction testing confirms Mr. MSR has influenza. He is clinically stable and the physician doesn't intend to admit him. So my question to you is, which of the regimens listed below would be the most appropriate for Mr. MSR now? Would you initiate inhaled zanamivir? Would you initiate oral amantadine? Would you initiate oral oseltamivir? Or is it true that we do not initiate any antiviral medication in such a clinical scenario? I'll give you 10 seconds to choose the correct answer. I would not initiate any antiviral medication in this case. Now, in patients with no risk factors for influenza-associated complications, both the CDC and the IDSA guidelines recommend against use of antiviral medications for influenza when the patients present more than 48 hours after symptom onset. Now, we are told MSR's symptoms have been present for 3 days and he has no apparent risk factors for influenza-associated complications, which include age of below 2 or above or equal to 65, chronic pulmonary diseases including asthma, cardiovascular diseases excluding hypertension, renal, hepatic, hematologic, or metabolic conditions including diabetes, and even immunosuppression, including HIV or even pregnancy. Now, all those many words explain why no antiviral medication is indicated, and that makes choices B, C, and A incorrect. Let's move to the next question, please. And it reads, Mr. KLM, A 67-year-old male patient is admitted to your general medical ward. He has a past medical history of type 2 diabetes mellitus. He is hypertensive. He has a history of heart failure and stage 4 chronic kidney disease. He is admitted for honk and acute kidney injury. Now, on the 4th day of hospitalization, he develops MRSA pneumonia. The clinical team is hesitant to treat using vancomycin in the setting of KML's improving acute kidney injury and the underlying chronic kidney disease. Remember, it's stage 4, and they seek your recommendation as the clinical pharmacist specialists in the infectious diseases team. So my question to you is, which of the antibiotics listed below would be the most appropriate for Mr. KLM's treatment now? Would it be telavancin, linezolid, ceftaroline, or would you settle for daptomycin? I'll give you 10 seconds to choose the correct answer. I would settle for linezolid. Remember, linezolid is considered equivalent to vancomycin for the treatment of pneumonia caused by MRSA, according to the current IDSA and the American Thoracic Society guidelines for the management of adults with hospital-acquired and ventilator-associated pneumonia. Now, this is based on evidence from 4 randomized trials demonstrating non-inferiority of linezolid to vancomycin. I would like to comment that daptomycin covers MRSA but should never ever be used for pneumonia, since it was discovered that it is inactivated by pulmonary surfactant after being found inferior to ceftriaxone for community-acquired pneumonia. Don't use it. Then ceftaroline covers MRSA and is FDA approved for CAP, but patients infected with MRSA were excluded from the randomized controlled trials leading to this approval. Therefore, I would not settle for it. And I would like to add that data regarding the use of ceftaroline for MRSA pneumonia are scanty and observational in nature, and that makes it less evidence-based as compared to the use of linezolid. Then telavancin was found non-inferior compared to vancomycin for HAP and VAP in a single randomized trial, but is suboptimal compared to linezolid for 3 reasons. 1, there is less evidence. There are just 2 trials, which included one MRSA subgroup analysis compared to 4 trials with linezolid. Then for number 2, there is the issue of nephrotoxicity, and the incidences are similar to those in vancomycin. Therefore, I would not use it in this patient. Then number 3, an FDA advisory recommending against the use of telavancin in patients with a creatinine clearance below 30 ml per minute due to a numerically higher incidence of mortality in this subgroup in the telavancin group in the randomized controlled trial with stage 4 kidney disease patients, clearance being presumably below the 30 ml per minute mark. A patient in stage 4 CKD, in my opinion, has a clearance below 30 ml per minute. So it would not be a good candidate for treatment with telavancin. Let's move to the next question, please. The next question reads, Mrs. KJA, a 29-year-old female patient, presents to your surgical intensive care unit with no known past medical history. She was involved in a road traffic accident and emergently requires mechanical ventilation. She subsequently develops a ventilator-associated pneumonia 72 hours after her admission to the surgical intensive care unit. And your SICU antibiogram is represented below or presented in the next slide. So there you have it. The E. coli, for example, is susceptible, 95% susceptible to cefepime, 73% susceptible to ciprofloxacin, 99 to meropenem, 95 to piptaz, and 90 to tobramycin. And it is 100% susceptible to, the H influenza is 100% susceptible to cefepime, 100 to cipro, 100% to meropenem, 100% to piptaz, and 100% to tobramycin. Then the Klebsiella is 93% susceptible to cefepime, 81% susceptible to ciprofloxacin, 97% to meropenem, 92% to piptaz, and 89% to tobramycin. And the Staph aureus is 73% susceptible to cefepime, 56% susceptible to cipro, 73% susceptible to meropenem, 73% susceptible to nafcillin, and 73% susceptible to piptaz, and 100% susceptible to vancomycin. Then the Pseudomonas aeruginosa is 91% susceptible to cefepime, 77% to cipro, 85% to meropenem, 86% to piptaz, and 94% to tobramycin. So my question to you is, basing on the above antibiogram, which of the regimens listed below would be the most appropriate for the management of Mr. KJA's ventilator-associated pneumonia? Would you treat it with vancomycin infused over an hour alongside cefepime infused over an hour to 30 minutes alongside tobramycin, or would you settle for vancomycin co-administered with piperacillin tazobactam and tobramycin, or would you settle for vancomycin co-administered with cefepime, or would you administer vancomycin plus piperacillin tazobactam 4.5 grams infused over 4 hours, 6 times daily? I'll give you 10 seconds to choose the correct answer. I would treat this patient with vancomycin infused over 1 hour alongside cefepime infused over 30 minutes, and that is in line with the current IDSA and the American Thoracic Society guidelines for the management of adults with HAP and VAP. Now, this patient requires coverage for MRSA due to a local prevalence of MRSA that is above 10 to 20%, and only single coverage for Pseudomonas aeruginosa. Now, the patient has no current or no apparent risk factors for MDR-VAP, such as the use of IV antibiotics in the past 90 days, or current septic shock, or even acute respiratory distress syndrome preceding VAP onset, and or even 5 days or more of hospitalization preceding the VAP onset, or even acute renal replacement therapy preceding VAP. She doesn't have any of those. She's here because of a road traffic accident, you remember. Then I would like to add that there is also a suitable monotherapy antisuidal mono agent, and that happens not to be an aminoglycoside. Don't use aminoglycosides for anti-pseudomonal coverage as monotherapy, because we are told in the graph that over 90% of the gram-negative isolates are susceptible to cefepime. That makes it a suitable choice as monotherapy coverage for Pseudomonas aeruginosa. Then I would like to add that combination therapy against Pseudomonas is considered unnecessary by the current guidance. And that therefore makes choices B and A incorrect because they employ anti-Pseudomonal combination therapy. They have more than one anti-Pseudomonal agent. And then choice D, vancomycin plus piperacillin tazobactam, is incorrect because more than 20% of Pseudomonas aeruginosa isolates are resistant to the piperacillin tazobactam, making it unsuitable for monotherapy. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly urge you to give it a thumbs up, to like it, and to share it widely with your peers. And if you haven't yet done so, I would like to humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come. And I thank you all very much for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and your very kind collaboration, and I look forward to interacting with you in the next video. Thank you very much.